Hello, ladies and gentlemen. Welcome back to this interview series here on the channel. This afternoon, I have the very great privilege to be joined by Dr. Phil McElnay, a previous NIHR academic trainee in cardiothoracic surgery, a previous medical director at GlaxoSmithKline, and currently and presently the CEO of MedAll, a MedTech startup. Phil, thank you for coming and joining today.
Absolute pleasure. Thanks for having me, Ollie.
Well, where to begin? I think there's such a storied list of things to get into. I think just to get the easy stuff out of the way first, can you just give us a bit of an introductory spiel on yourself?
Yeah, I mean, you've kind of hit the key nails on the head there. I guess I trained in Glasgow. I was an undergraduate in Glasgow. I jumped into surgery after F1, F2, and having taken a teaching fellowship year in Bristol. And that happened after me not getting my job in cardiac surgery the first time. So I applied for cardiothoracic surgery straight out of F2 and didn't get a job. And I think there were 8 jobs in the country that year, and I came something like ninth. So just missed. And so then suddenly having to figure out what I was going to do, and that was what, eight-ish years ago. And at that stage, it was actually a little bit frowned upon to take a year out after F2. But I took a teaching fellowship at Bristol University, and it was great. And then reapplied for cardiothoracic surgery, and was fortunate enough to get it was actually the only academic number that year in cardiothoracic surgery in the UK. I had a great time and really enjoyed it. And then jumped into industry, worked as a medical director in rare diseases at GSK in London, which again was a hugely interesting experience. And then throughout that, I saw some things. I sat on the Association for Surgeons in Training executive, and through some work at GSK, both of those things exposed me to a couple of training systems around the world for healthcare professionals that scared me, shocked me, gave me a little bit of drive that things needed to be a little bit better in how we train our doctors. And it was with that sort of motivation that I then founded MedAll, which is essentially a Wix or a Bubble or a GoDaddy builder for e-portfolios for healthcare organizations around the world, so that they can introduce competency-based training for a fraction of the cost that it would otherwise cost to go and get a developer to do that sort of stuff.
Amazing. Well, like honestly, the list of things, we've only got Phil for a very limited time this afternoon, so the list of things to cover. I think we'll skip medical school, as much as it pains me to say. I think it's worth asking. We've not had anyone talk about cardiothoracic surgery on the channel so far. So, just for the benefit of the boys and girls at home, brief summary: what is cardiothoracic surgery?
Sure. And at this stage now, after being out of that for a few years, there's definitely more qualified people who can talk about cardiothoracic surgery than me. But it's a hugely exciting specialty. Combines cardiac surgery in one half and thoracic surgery in the other half. So it does exactly what it says on the tin. And you treat conditions of both the heart and lungs. Cardiac operations, I guess the most common ones that you do are coronary artery bypass grafts, CABG, cabbages, for acute coronary syndrome or ischemic heart disease, and valve replacement, whether that's aortic or one of your other valves, but mainly aortic. And then thoracic, it's predominantly an oncological specialty. So you are treating lung cancer as one of the main things that you're treating. You're cutting out lung cancer from people's lungs in various different modes, whether that's minimally invasive surgery or open surgery, increasingly minimally invasive, or VATS, video-assisted thoracoscopic surgery. And they treat other conditions as well. So removing bullae from people's lungs or treating pneumothoraces. Lots of different things that you do, but mainly heart and lung surgery. It's 8-year training program in the UK, run through from ST1 with an option to join as an ST3 if you've done some surgery as a CT1 or CT2, but predominantly a run through specialty now. And then you can do some subspecialty training after that in pediatric cardiac surgery if you wanted to be a pediatric cardiac surgeon. It's not a dying specialty, I suppose, is one of the things that everyone is told, and I was told constantly. And I think for a period of time in the UK, there were actually no jobs for trainees, but that's not the case anymore, and there are jobs in the specialty. And certainly in thoracic surgery and lung cancer operations, I think there's going to be scope to continue to operate for many years to come. So it's not dying just yet.
Amazing. So again, just to briefly clarify for the benefit of listeners at home, a couple of things that Phil has said there. It's a run-through specialty, which means that you do your Foundation 1 and your Foundation 2 years as a junior when you leave medical school, and then you can go straight into specialty training rather than doing the more generalist, even generalist surgical training that you might do for other pathways. And I think you've also kind of hinted there in the lack of jobs. It's a very, very competitive specialty. Potentially, I would say one of the most competitive specialties in medicine.
It's up there for sure, yeah. It's up there for sure.
Definitely among surgical specialties. It seems to me to be about the top thing you can apply for. And then the other thing you said is that you were an academic trainee in surgery. And I think we've not discussed this on the channel before. So what's the difference between a quote, normal surgery trainee and an academic trainee?
I don't know if there ever is a normal surgical trainee.
Quite.
But yeah, I know what you mean. So what is an academic trainee? It's essentially giving you formal training in doing things academically, right? Whether that's research or education or leadership, predominantly research. Certainly in cardiothoracic surgery, it's predominantly research. And you do that concurrently whilst you're doing your clinical training. So you will do, you can do an academic foundation program, and it's very similar to doing an academic foundation program where your time is split between academic activities and clinical activities. For postgraduate specialties, then, respiratory medicine or psychiatry or pediatrics or surgery, you then enter what's called an ACF, an academic clinical fellowship, which is formal academic training in that specialty. Those are usually 3-year posts, and at which point you are, at the end of that, you're meant to be in a position to be able to apply for an external fellowship for funding for a PhD or similar, and then after that, then you can apply for academic clinical lectureship. So also an NIHR post, National Institute for Health Research post, where you spend some time doing research and some time doing clinical work. And then after that, you can apply for a clinician scientist post or another senior academic post, which runs concurrently with being a consultant. So you are a senior lecturer or something, you usually are an academic consultant at that point, where again, you spend some time doing research and you spend some time doing clinical stuff. And it's kind of like the long wedge of academic training, right? So you start out with a little bit of academic in your foundation training, but still mainly heavily clinical. And then as you go through that training pathway of ACF, ACL, clinician scientist, or academic consultant of some description, heading towards professor, you're doing increasingly more academic work and usually increasingly less clinical work. But the competencies you have to achieve as a clinical or an academic trainee in your clinical work have to be the same, whether you're doing academic or clinical training. The academic bit essentially means you're doing stuff on top of clinical training.
Amazing. I mean, it sounds like one of those things for people who like to be perpetually busy, or I guess to be called professor, or some combination of the two. It's but obviously from what you said in the intro spiel, you ultimately decided that surgery wasn't for you full time. Right.
Yeah, I mean, that's it was a big decision. That was a scary decision to make. I was surrounded by wise, passionate people at the time in cardiothoracic surgery, right? My supervisor, who was Professor James Cook Hospital, hugely supportive. I initially did it as a way to get more experience and learn about a different sphere of the academic world, right? That you actually get very little exposure to as an undergraduate. In fact, it's often frowned upon as an undergraduate or medic to actually work in industry. But for me, it was a really interesting time, right? You get exposed to the nuts and bolts of how this stuff happens and the nuts and bolts of what it actually takes to get a new therapy from bench to in a sealed foil packet being delivered to a patient, right? And for me, it was kind of about what gets me out of bed in the morning. And I like to be busy. I'm not particularly interested in being called prof, but I certainly like to be busy. And I like the mental challenge of difficult things, right? That for me, that gets me out of bed in the morning is if I have a routine where I'm doing kind of the same thing every day, I get really bored really quickly. And actually what was getting me out of bed in academic cardiothoracic surgery was not just the operating, right? Like that's hugely exciting. How can you not find opening someone's chest and putting them on a bypass machine and stopping their heart? How could you not find that interesting, right? That is very interesting. Cool. But actually doing that every day, I was thinking for the rest of my life, probably is not going to get me out of bed in the morning. You know, it's going to get slow very quickly, actually, when you start to do that every day. And what was interesting to me was the research side of it. So working on some cool research projects and seeing a big picture of you can actually make an impact on more than just the patient who's right in front of you on an operating table, or more than one patient in clinic, or even more than the 10 patients in clinic you're seeing. But if you're working on a big clinical trial, actually you've got the ability to design something that is much bigger than you and actually makes a much bigger impact on a patient group or a patient population. And that's exactly the stimulation I got working at GSK. We were working on a treatment for amyloidosis, and so it was actually a nice segue in from cardiothoracic surgery. I was the global medical director for amyloidosis, so was the single patient at GSK who, or the single person at GSK. Did I say patient?
I was going to say that's not much of a clinical trial.
I was a single person at GSK who was the go-to point for doctors who were involved in the treatment of amyloidosis, and you get a really broad viewpoint of how this is managed across not just the UK, right? I was never going to be the expert in amyloidosis because there are many much smarter people than me who are involved in treating these patients and do a wonderful job at it. But what it did give me, and I think I maybe became for a very short period of time, an expert in how the different countries manage amyloidosis, or the system set up for managing patients with rare diseases, how that happens, and some of the differences and challenges. And for me, that was really exciting. You know, you got to dive under the bonnet of a rare disease that had no treatment, and you're working on a sort of first-in-class drug for treating these patients who are desperate to get some form of treatment for their condition, and ultimately seeing that through from a trial to a file with the FDA and the European Medicines Agency, and now it's a medication that is used by these experts who treat amyloidosis, and these patients now have a medication. Was hugely, hugely humbling and satisfying to actually do. And for me, that big picture stuff of actually I get to have involvement in a world-class study that is first of its kind, impacts loads of people, and makes a real difference was the sort of thing that was going to get me out of bed for forever. And in some ways, it's kind of similar to what I'm doing at the moment in terms of the big picture stuff and impacting more than more than one person who's right in front of you, which is still important, right? But for me, it's kind of about the mental challenge of trying to fix something that can impact more people. It's a very long roundabout way of saying whatever gets you out of bed in the morning, choose that.
And honestly, that's fantastic advice, because that what you just said is, and the justification almost, or the feeling behind it, is something that I hear a lot from people who work in MedTech. That's one of the big things, and in public health as a specialty. This drive to help. It's all well and good treating one person in front of me, but if I can make an intervention that gives us 1,000 QALYs, elsewhere across our patient population. Equally, I remember asking an orthopedic trainee once, on a similar note. I said, what do you want to do? And he said, I want to be a knee surgeon. I want to be a really good knee surgeon. And I sort of said, so you're going to come in every day, you're going to replace knees, and you're going to do that like every day for the rest of your life. He was like, yeah, because I really enjoy it and I'm going to be really good at it. I'm going to be the best in this hospital at doing, this operation. And it was very much that, actually that is just what that guy wants to do, and different motivations as such.
Nothing wrong with being niche, right? It's whatever motivates you, right? There's no one way to live your career, or I think that's previously how things were in medicine. You had to previously just follow a track, and it was frowned upon if you did something different. But I think increasingly we're kind of catching up with the rest of the employment world, right? Where if you just stayed in one, take GSK for instance, right? If you stayed in GSK for 20 years, you'd almost be like frowned upon, or not frowned upon, but an eyebrow would be raised, like, why have you not gone somewhere else and got some more experience?
Certainly, yeah.
So there's a little bit of that in medicine, and I think we're catching up.
Yeah, definitely. Particularly in I guess, people. It's funny you should say that, because I feel certainly the people that I deal with at interview stage, one of the things you're almost taught to say for the purposes of the hidden curriculum is all these amazing career options that medicine, I could go and work in industry, I could go and work in law, I could go and not do medicine at all. Yet actually, when people particularly put training on hold or leave training to go and do these things, it does raise eyebrows, right? In the more puritanical circles. So it's good to hear that progress kind of is coming about. But I think one of the major questions that I had from viewers when I advertised that we were going to have this talk was about MedAll and establishing your own MedTech initiative. So why don't we talk, what is MedAll? What's the motivation?
Yeah, so the main motivation is improving global medical training. You'd be pretty shocked, actually, if you took a snapshot view of most healthcare training systems around the world about how it's currently done. In some countries, we're really used to doing competency-based training constantly. You're used to being assessed and credentialed against a curriculum, and you're used to getting feedback from people and people signing forms off for you to say that you can nodding, yeah, that you can take blood or stick dips, and you get fed up, sick and tired of it in some ways. But it actually makes doctors who are trained in that way some of the most examined, most assessed doctors in the world. And ultimately that means as a patient that you get a very consistent level of care from your doctor or from your nurse or from your physiotherapist if they've been trained in that way. The World Health Organization says that globally there are grave deficiencies in the process of competency-based training in healthcare disciplines. In some countries, actually, when you finish your training as an undergraduate, you pop off the end of undergraduate training and you just have a lifetime registration. You're never reassessed ever again. And you continue until the end of your career, and no one knows whether you're competent or not. In specialty training, as a postgraduate in some countries, it's purely time-based. So as long as you spend 4, 5, 6, 8 years working with someone in that specialty, again, you pop off the end as a consultant cardiothoracic surgeon. I was talking to one team this morning in another country who were saying exactly that. So as a specialist in cardiothoracic surgery, you're assessed once at the end of your training program of 5 years, and as long as you do a decent enough operation at one time, then that's you popping off the end. And to people who are not in that system, it's almost unthinkable that is how that happens, but it is. And a big barrier to actually introducing competency-based training is the amount of work that creates for a healthcare system. How do you begin to credential, benchmark, test the competency of an entire medical training population? Either you do it all on paper and you create mountains of bureaucracy and admin for people, or you use a bit of technology that actually does that for you. And that's what we certainly use in the UK. We have e-portfolios. It's done electronically and is much more efficient than doing everything on paper. What we do.
Can I just quickly interject so what's playing on my mind there though is that what we you didn't specify which country this was, but certainly they obviously have the requisite resources to be talking to you. Like they're not kind of in the midst of nowhere with no resources. And what I will charitably assume we don't have is a load of cowboy or indeed cowgirl cardiothoracic surgeons, doing monstrously bad operations and killing everyone. So how do you find in your obviously estimation as a kind of expert in these things, how do the outcomes for patients compare? Despite this lack of competency-based training, are the patients still doing well?
It's not just about patients, right? So it's about patient outcomes. Absolutely. It's really hard to correlate those two things. How do you ever correlate what one person's done versus another if you don't have the data? It's almost impossible. So it's about efficiency as well, right? So so once those people graduate, there is some evidence to suggest that it takes a little bit of time for them to actually get to the point where they can be independent practitioners. So you're training for 5 years. If you're not sure about the competency of someone, then you may have to be under the tutelage of another consultant or attending or a specialist for a period of time after you finish your training. And that uses resources, right? So you're not training necessarily independent practitioners. You're training people to pop off the end of a system that then they still need to do some more training, and that happens in a number of countries. But certainly from a global perspective, this is a mandate from the WHO, that we have to introduce competency-based training, and it stands to reason, right? You wouldn't expect this in any other sphere. It's really hard to grade without necessarily having the data in those countries, because of course if you're not collecting data, you don't have much data to work on, right? As to who's competent and who's not competent. You're not collecting the data, so it's there's a little bit of bias in the study there if you were to create one. But it stands to reason, right? It's common sense that actually if you are competent and you're assessed as competent and there's something that says you're competent, then more than likely you're competent, right? And that you can go off and practice. And as a patient, there's a little bit of security there. So translate it into the airline industry, right? Could you imagine an airline industry where so long as you spend 5 years in the cockpit with someone, grand, work away, fly the plane, there you go, there's the keys, good luck. Would not happen, right? And there's a little bit of, it's got to be evidence-based, but there's a little bit of common sense being introduced into the system there as well, and saying actually this absolutely makes sense from a training perspective, but also from an efficiency perspective. So there is some evidence from an efficiency perspective that it reduces the amount of time that people have to spend under the tutelage of someone else. But also you can start to make efficiency savings for administrators and consultants and trainers who don't have to be rifling through paper documents. So it's not just when there's no system, but when there is a system and it's paper, it's also highly inefficient. So asking healthcare professionals how long they spend reading through logbooks or portfolios at the end of a training program is an interesting question, right? So, and often we'll spend about 1 to 2 hours rifling through a logbook at the end of someone's year or the end of their training program, depending when they're doing their assessments. And you scale that up across 85, 100, 200, 10,000 trainees, and the amount of man hours that you're getting someone very senior to rifle through sometimes quite tatty bits of paper is crazy, rather than just having one system that makes them more efficient and they can get on with their job of actually training people. And there is some evidence to suggest that can be done. But if you don't have the evidence in the first place for the companies, it's very hard to actually evidence it. But it stands to reason, and we hope to be able to plan that actually with the evidence we can correlate that with outcomes. But you need to collect the evidence first.
Amazing, and I mean, how I don't know how long MedAll has been going, but what's your adoption been like?
Yeah, so we actually incorporated in 2017, so almost 3 years ago. It's hard to believe. And at the time, we essentially started creating a place just for people to dump all of their certificates and so on, like the chunky paper folder that you have for your portfolio, right? The virtual version of that. So allowing you to store it in a single place once forever. And that was okay, right? But a little bit painful for people to use. And there's a really good story in there about building a MedTech product or organization. That was kind of your first question about how do you get off doing that. And we started building, I guess, before we started testing. And it was only really about 6 months ago that we kind of pivoted, I suppose, into thinking about the organizational component of this, and actually this is a big issue from an organization's perspective, and a lot of it's about affordability. They can't afford the hundreds of thousands of pounds it takes to normally implement this sort of e-portfolio technology, and that's why a lot of them are still using paper, and why some countries are not doing anything at all. So the more organizations we started to talk to, we began to realize that actually this is something they wanted, but was maybe a little bit tricky for them to implement. And then actually going off and thinking about that and thinking about, okay, well, how do we incorporate that into a tool, and how do we build something that actually people want, and not just want, but love, right? How do you build a product people love is really important. And just by having a big place for people to dump their paper certificates, it was okay. People were using it. We're in the thousands of users. But did people love it? I don't think they did, right? And who can get truly excited about paper or going paperless? It's the most meaningless thing, right? Is just going digital for the sake of going digital. Why would I do it? Okay, yeah, it makes my life a little bit easier, but not massively. Sure. But actually, if you can start to implement some of those competency-based tools so that organizations can implement technology that they've wanted to implement for years, but have never been able to afford or didn't want to pay for the expensive developer to go off and build their work-based assessments for them, and they can just build it themselves and do it for very little cost or free in some countries, then you solve a really big problem. And so, yeah, about 6 months ago, we pivoted into that, and it seemed to get traction and start working. So we very quickly got a soft commitment from a very large medical NGO to use the tool based purely on wireframes and designs. And then since then, another medical school, a college of medicine in a country for a specific specialty.
The most obscure.
Yeah, well, I can't really go into the details of it, but so some big organizations, which is great, and we're still working with designs, right? So and that is how you truly build a MedTech organization or product. Don't start building, stop building, put your tools down. Do not build. Go and talk and listen. And so this week I've spoken to people in maybe 15 different countries, listening to how they do training, listening to what they're using as a logbook or portfolio. Many of them are still paper. Many of them have problems that I never would have considered. Fraud, for instance, in some countries is a big problem with logbooks. If a medical student is a bit rogue and just wants to get things signed off, they'll go and and fraudulently signed some of the logbooks as another senior member of staff. So they have some issues there, which if you're introducing a digital fingerprint, it reduces that issue. So there's, getting out, talking to people and listening to them is one of the most important things that you can do before you start building at all. And it's probably the thing that I learned, right? So we started building and then listen, right? Wrong way around. So listen and listen and listen and listen and talk and listen before you start to build, and only then write some code. And so we're only getting to that stage now of really writing some code for that new e-portfolio, that Wix for e-portfolio builder. We're only now starting to do that after 6 months of talking and listening and designing. And in the middle of coronavirus as well, the world's eyes kind of shifted onto healthcare, which was interesting. Posed a little bit of a challenge. I think the other thing, if you're going to build an organization, is about funding and how do you make that happen. And you need to be reliable if you're going to start building anything in MedTech. Your organization needs to be reliable. Your resources need to be there so that you can provide the appropriate support, and that needs funding. One of the big things that came out of the coronavirus crisis was, as I say, the world refocusing on healthcare and investors thinking about what is important to them. And suddenly door-to-door noodle delivery, door-to-door noodle delivery probably was important in lockdown, dissolving noodles, or tie-dye t-shirt ordering, whatever, online was no longer the big priority, right? Actually solving healthcare was suddenly the big priority. We were really fortunate a number of months ago to get an investment round from some of the best investors, I would say, in Europe. So we got investment from Seedcamp, which is, if you typed in best pre-seed investor firm in Europe, Seedcamp would be in the top 3. They've also invested in TransferWise, Revolut, some really good people, and that community is now getting behind healthcare and saying, actually, we agree, this is an important issue, and they've all been kind of scared to tackle healthcare because it's a scary place to do innovation, and often healthcare can be quite hostile to anyone in the private sector, number one, but also to people doing innovative things can sometimes be a little bit hostile and slow to adopt and so on, and that has historically put investors off, and we're kind of seeing that change now. So kind of our responsibility as healthcare professionals is to channel that and put it in the appropriate places and use those resources wisely. So talk to people before you build and make sure you're well resourced are the two sort of key things I would say before you start to dive off into MedTech.
Amazing. So I've got one very last quick question for you, which I know will come up based on what we've said. So what I guess people ask is, if you have embraced this startup, the MedTech, this kind of life, as it were, like this is, as you say, what gets you out of bed in the morning. What's your relationship with clinical medicine like at the moment?
Right. Good. Yeah, I still love it. Right. I don't think anyone who has been a doctor walks away from clinical medicine and says, goodbye, good riddance, never want to do that again. Well, I guess some do, but most.
Yeah, I've met some.
Most of us still enjoy a little bit. So I still do a day a week of clinical practice. You'd be glad to know nobody wants a 1 day a week cardiac surgeon. I certainly wouldn't want a 1 day a week cardiac surgeon operating on me, quite rightly. So I work predominantly in A&E at the moment for 1 day a week, and that keeps me keeps my finger on the pulse, I suppose, with healthcare, what's important in healthcare, and also helps me retain my license, which is important as well. It's a valuable thing that's had many years invested in it. So it's important not to throw that out very quickly. Anything in health tech is risky, right? Anything in tech is risky, and you might be here going tomorrow, or it might take off, right? It's a big risk to take. So walking away from your medical license should never be done lightly. And for me, I still keep it, and I actually enjoy still doing a day a week of emergency medicine, and I still enjoy seeing patients. Patients are wonderful, keep you grounded, and remind you of what's important in life. So yeah, my relationship with clinical medicine is good, one out of love, and it will continue.
Perfect. Well, what a way to end. Dr. Phil McElnay, thank you for joining us today. We'll leave links to all your various projects down in the description below. Thank you so much for joining us.
Thanks for having me, Ollie.
No problem. Take care.